This is Kevin Magone, shoulder and elbow fellow at NYU Langone Orthopedic Hospital in New York. And this is a case presentation of an arthroscopic tuberoplasty for irreparable rotator cuff tear. This surgery was performed by Dr. Young Kwan, Associate Professor in the Division of Shoulder and Elbow Surgery, again at NYU Langone Orthopedic Hospital in New York. The authors for this presentation do not have any disclosures pertinent to this presentation. Indications for an arthroscopic tuberoplasty is of course an irreparable rotator cuff with preserved motion and minimal glenohumeral arthritis. Specifically, the patient will have preserved forward flexion at least to 125 to 130 degrees, and the goal of this operation is to relieve impingement or end of arc pain without disturbing the coracoacromial arch. The case is a 52-year-old right-hand dominant male with right shoulder pain for 3 months. He is an avid lacrosse player and weightlifter and heard a pop while working out 3 months ago. Now he reports weakness and continued pain. There's no significant past medical history. He does have a surgical history of a right arthroscopic labral repair 3 years prior. He also has 2 previous rotator cuff repairs and biceps tenodesis 3 and 4 years prior. On exam, he has forward flexion to 160 degrees, external rotation to 30, and an internal rotation to the third lumbar vertebrae. He's slightly weak with forward flexion and external rotation, mainly due to pain, and he does not have any lag signs. X-rays of the right shoulder, we have an AP and axial radiographs, show previous hardware placement and the greater tuberosity with minimal arthritic changes without a superior migration of the humeral head. The head is otherwise concentric within the glenoid on the axillary view. MRI images, we have a T2 coronal and sagittal images show a full thickness retracted rotator cuff tear with, again, previous hardware placement and the greater tuberosity. Axial and sagittal image of the right shoulder reveal the subscapularis is intact and minimal fatty atrophy is noted on the sagittal images. Once the rotator cuff has been deemed to be irreparable with debridement and releases, attention is brought to the greater tuberosity and a thorough debridement of the footprint is performed. You are viewing from a posterior lateral portal with a 30-degree arthroscope and a motorized burr introduced in the lateral portal. Debridement starts anteriorly near the bicipital groove, and with internal rotation of the arm, you continue to work posteriorly until you encounter intact rotator cuff. The intact rotator cuff should not be disturbed. Again, attention is to the greater tuberosity to minimize impingement or end of arc pain without disturbing the undersurface of the acromion to disrupt the coracoacromial arch. Rehabilitation for a reverse decompression or tuberoplasty. It consists of a sling for 1 to 2 weeks for pain control. However, active motion of the elbow, wrist, and hand are performed immediately. When pain allows, within 1 to 2 weeks, passive and active assisted shoulder motion is initiated. There's no heavy lifting or strengthening, however, for 6 to 8 weeks. Thank you.